much for having me. Thank you to Grigoris and the University of Atticon for inviting me today. Could I have my slides, please? I have a confession to make. I don't speak Greek, so this will be in English. My name is Pareek. I'm a consultant cardiologist and an adjunct lecturer in King's College Hospital in London. So we're here because coronary artery disease is the biggest cause of death globally. And it all happens, most of it happens, because of a very simple process. A coronary artery plaque ruptures or coronary artery plaque has disruption. You then get a maladaptive thrombosis, an arterial occlusion, and ultimately myocardial infarction. And our understanding of this process has improved considerably when Mason Soanes inadvertently cannulated the right coronary artery in 1958. I'm not sure if you know the story, but he was doing an aortic angiogram and the pigtail slipped into the right coronary artery and he injected a lot of contrast. The patient had an asystolic arrest, but they somehow saw that as a success. And the selective coronary angiography was born. If you look at that picture, really, angiography only gives you two things: lesional severity and the acute occlusion, which is great because we can then stent things. And this is probably one of the most important and transformative procedures in modern medicine. But there are very many limitations. We are unable to understand morphology, mechanisms, and also the natural history of the pathophysiological process. So our generation is quite lucky. We're sort of really in the renaissance of intracoronary imaging. Over the last 40 years, we've had a huge growth of all of these technologies. It's amazing to think that IVUS has been around for over 30 years. We've had OCT at least for over 10 years clinically. And we now have access to super dual modality catheters such as NIRS IVUS. So these three modalities all give us a huge range of intracoronary imaging in clinical practice. They have positives and negatives, but I really do feel that in conjunct we can use all of them in our daily clinical practice. And this is the wealth of information that we can receive from intracoronary imaging. You can get the normal angiogram with trilaminar architecture, the fibrous, the calcific plaque, the red thrombus, and even non-atherosclerotic processes such as SCAD. And as I said, with dual modality catheters such as NIRS IVUS, you can get more nuanced characterizations such as the lipid core burden index, or understand mechanisms of disease such as rupture and erosion. You're seeing so much more than the 2D luminal angiogram. So I think there is certainly a role for more specific and specialized situations. So I think that intracoronary imaging is useful for stent failure and in-stent restenosis. We can understand with the role of intracoronary imaging the mechanism and mode of failure and then apply therapies accordingly. We've also had a growth of calcium modification techniques, IVL, orbital atherectomy, etc. And intracoronary imaging and understanding the calcium modification, I think, goes hand in hand with that very well. And finally, of course, the left main stem, where although there's no real, true randomized controlled trial evidence, there's certainly a wealth of data suggesting benefit for intracoronary imaging. But how about routine use of intracoronary imaging in every single case in routine practice? Well, there are now systematic algorithms aimed to improve incorporation of intracoronary imaging into our daily practice. These provide a protocol and then targets for each of our angioplasties. And there's several of these. The most well-known are IVUS XBL, Ultimate, and the Illumian 4 criteria. And our industry collaborators have made snappy slogans such as MLD Max and Boston 123. But ultimately what they do is they enable the clinician to size the vessel properly, find your normal landing zones, interact with the plaque morphology, and also provide post-stent optimization, which we all do. Well, that all sounds great, but does it actually work? Well, over the last 10 years, we've had a number of small-scale studies which have suggested benefit. But about a year ago, we had the publication of Renovate Complex PCI, which I think was really a line-in-the-sand moment for intracoronary imaging. This was published in the New England Journal of Medicine. 1,600 patients from Korea randomized to angiography-guided PCI or imaging-guided PCI based on operator discretion. Ultimately, 80% had imaging-guided PCI. On the left-hand panel, you can see a 5% absolute risk reduction in the composite endpoint of target vessel failure. But on the right-hand side, you can see that those patients who ultimately were able to treat according to protocol had most benefit. So it's not just putting the catheter down, it's also about interacting with the image. Later that year, we had the Illumine 4 study published, which was led by Ziad Ali and colleagues. This study randomized patients to OCT guidance with the Illumine 4 protocol compared with angio alone. And the first co-primary endpoint was positive, a final MSA with OCT compared with angiography, but ultimately did not lead to improved target vessel failure, and we can perhaps discuss this later. In the same hotline trial at the ESC, Greg Stone then presented his network meta-analysis, where he looked at over 20 randomized controlled trials and 12,000 patients. And in this, you can see that the odds ratios are really quite remarkable. All of them show benefit towards intracoronary imaging. And then if you look at the absolute numbers, they're really quite frightening. Target lesion failure reduction, 31%. Cardiac death, 46%. All-cause death, 25%. So if you think about it, we're now in the era of non-inferiority stent trials. These are really very striking endpoints. But then we can move forwards. Instead of treating the severe angiographic lesion and applying imaging to that, well, how about maybe the non-severe lesion? Well, the Prospect 2 study showed us that if you have a plaque burden of over 70% and a lipid core burden index over 325, you have, and compared to those with none of those features, you have an over 10-fold increase in MACE out to 4 years. And the Prospect Absorb study, albeit limited by the Absorb scaffold, suggested that you can pacify those lesions. The Forza trial I found interesting too. They randomized what they describe as ambiguous intermediate culprit lesions, either into FFR guidance or OCT by the Forza criteria. And they followed them out to 13 months, and you can see that there was a reduction in angina and MACE at this time point. So moving away from the angiographic approach to lesions to an intracoronary imaging one. So where are we with guidance? Well, still a 2AB recommendation for IVUS or OCT, even for left mainstem, quite surprising, I think, but outmoded, and these are over 6 years old now, and I understand these are due to be upgraded, and I really do feel now is the time for 1A recommendation. So in summary, intracoronary imaging enables us to understand the disease process. There really is a wealth of evidence now, and I think it is time for a 1A recommendation. There is much work to be done, and there is more progress on the Athenan horizon, I'm sure. Thank you.
Thank you very much, Dr. Pareek, for your excellent talk. We'll have the chance to discuss it at the end. But I think at the last part of your talk, you pointed the data were convincing. It's important. It's useful. But of course, we need higher penetration in everyday practice. And I would agree with your final statement that probably the upgrading the guidelines should take place. This will help everybody to use imaging in a more widespread manner. Grigoris, brief question because we'll discuss at the end.
So, Niles, first of all, thank you so much for traveling from London to be in Athens to be with us.
Thank you.
That was a fantastic talk. I know very well that you are a heavy OCT user and a true believer, as I am too. and I know that you are involved in Lumion 4. We expected to see a difference in the primary outcome. Why do you think that the study didn't show a difference, at least in the primary outcome?
Yeah, thanks, Goris, and also thanks for inviting me. First of all, I think there's one of the main reasons we didn't see a benefit of Lumion 4 was that the event rate overall was lower than expected. It was powered at approximately 15% target vessel failure at 2 years in the angiography arm. What you have to remember, I'm not talking about myself, but other operators in the study were pretty experienced operators. So you weren't comparing, an average sort of number of PCIs per year with OCT versus not. You had some pretty experienced operators. And secondly, there was quite a strict protocol, a bit like the October protocol. So you had to pass many tests, even just to get into the study. So there was a sort of a leveling up of all of the procedures within Lumion 4. So I think that was a trial effect, I believe, for that study. They talked about COVID in the actual presentation. I'm not sure we can we can blame it all on COVID. But I think that was one of the reasons. I think that actually we're getting pretty good at stenting generally. The technologies are getting better, and I think that the event rate was lower than expected. My suspicion is that out to 5 years, the curves will continue to separate.
Okay, thank you. We'll proceed. Next speaker is Dr. Pulημένos, known